Hello, you beautiful people. I have come up with an interesting topic of cardiology, and I have a patient with all the signs and symptoms of aortic regurgitation, and I'm glad I could recognize them all. I am here with you to share my experience and knowledge. Please keep on watching. Aortic regurgitation. It can be due to aortopathy, that is, the aortic root can be involved in this, and it could be also a wall problem. So the causes are the congenital one, that is the bicuspid aortic wall, or the quadricuspid wall. Valvulopathy, that involves the rheumatic heart disease, of course, and infective endocarditis. Calcific degenerative one, it could be a trauma also. Coming to the iatrogenic one, we can have a bicuspid aortic wall because of surgery undergoing, or we have a VSG with an aortic regurgitation and a subaortic stenosis. Now, these are the causes. Now, we could be dividing the causes into valvulopathy and we could be dividing into an aortopathy. But being a clinician, you could recognize that the age could be one of the most important thing, and of course, the systemic hypertension could be one other thing. So the patient would be coming up with you with the hypertension, with increasing age, and then they'll be complaining of palpitation, of course. And if it is a decompensated aortic regurgitation, the patient will come up with the pedal edema, ascites, breathlessness, and so on. So we have divided the causes because it would be easy for us to have a good theory, and we could understand the topic very well. So, valvulopathy, of course, the rheumatic heart disease, infective endocarditis, aortic stenosis, and these are the walls which are actually causing the problem. It could be an iatrogenic, bicuspid aortic wall, right? And as the age increases, there could be calcification and degenerative changes. Of course, there could be also trauma. And then coming to the valvulopathy, the aortopathy. So that means that could be aortic root would be somewhere compromised. It could be because of the systemic diseases like that of syphilis, or it could be because of um, inflammatory bowel disease, Behçet's disease, or we have Marfan's, ankylosing spondylitis, Hitter's arthritis, Takayasu, as I said, hypertension, age, aortic dissection, okay, and rheumatoid arthritis. Aortic regurgitation could be a chronic one or could be a acute one, right? So let's see the hemodynamics of the chronic aortic regurgitation. So say we have this is the heart and this is the aorta, okay? Uh, this is the ventricle, of course. So if there is any aortic regurgitation, that means the blood is flowing back into the ventricle, that is the left ventricle. So there would be, of course, increase in the left ventricular end diastolic pressure because increase in the left ventricular volume, right? So this increase in the left ventricular end diastolic pressure will cause increase in the preload, right? And so the heart will be thinking that I have much of the water, I want to pump it and then give that blood to all the other organs. So it will start pumping, right? It will start increasing the heart rate and it will start pumping, right? If as long as the heart is okay, it will pump, and so there will be increase in the systolic blood pressure, right? But again, during the diastole, the blood will fall. Okay? So there is decrease in the diastolic blood pressure. So there is much increase in the systolic blood pressure and there is decrease in the diastolic blood pressure. So there would be much increase in the pulse pressure because the pulse pressure is nothing but it is the systolic blood pressure minus the diastolic blood pressure. So there will be increase in the pulse pressure. Then if the left ventricle is damaged, okay, it is failed, then the blood will not be pumped, right? So the LV pressure will be decreased because it is not able to pump, okay? So there will be decrease in the left ventricular end diastolic pressure, but this is the last stage thing, okay? So the LA pressure is equal to the LV pressure. then LV pressure is equal to that of the aortic pressure. So as the force of contraction has increased, no blood remains in the ventricle. But when the LV fails, there will be increase in the left ventricular end diastolic pressure. Coming to a decrescendo murmur. So we have, this is the very important murmur. As my patient has arrived to me, she has come with me in a decompensated state with the complaint of breathlessness. There was palpitation, there was dyspnea, and so I had to take care of that symptoms also, of course, and I wanted to do the 2D echo. Now, many of our settings, their bedside 2D echo is not possible, so I needed to calm the patient. I needed to settle the patient down by using diuretics and supportive management, and then I could get the 2D echo done. Okay, so this is the decrescendo murmur that is there. So we have the end diastolic murmur. It is nothing but it is the end diastolic murmur that is seen. So the length of the murmur is directly proportional to that of the severity, right? We have come across this. We know that the length of the murmur is directly proportional to that of the severity. So here are the different murmurs I have taken this photo from, right? So we are familiar with that of aortic regurgitation now. Then, whenever there is the increase in the end diastolic pressure, right? So left ventricular end diastolic pressure is increasing. So of course that will increase the ejection fraction, right? We all know that, right? And and as the blood has to be pumped, right? So the preload is also increasing and the afterload is also increasing. So according to the Laplace law, the radius is directly proportional to that of the left ventricular wall thickness, right? And when the radius is increasing, the wall thickness will be also increasing. So there will be LVH, and so because the blood is being pumped hard by the heart, right? So coming to the chronic decompensated aortic regurgitation, that means the patient has been in a decompensated state. That means the heart cannot function well now. So there is increase in the left ventricular and diastolic pressure, right? And the EF goes as the left ventricular fails. Blood cannot be pumped. We have already discussed this. So this is the blood that is staying over in the left ventricle. Dyspnea is a late manifestation, of course, and there will be increase. So there will be the back pressure that will be present, right? And that will lead to that of pulmonary edema. But this is not in the case of acute AR, right? In acute AR, the patient will, it is an emergency condition and the patient will be presenting to you with the tachycardia and shock, hypertension, cold extremities. That's it. No other peripheral signs, nothing. No pulmonary edema, okay? Nothing. Then there will be increase in the JVP, and there will be ascites, there will be hepatomegaly, there will be pedal edema, right? So coming to the severity of the aortic regurgitation, whenever there is a bradycardia, that means the blood is not being pumped, that means there is an increase in the AR, it is correlating with the severity, directly proportional. But when there is tachycardia, that means the left ventricle functioning well, that means the blood is being pumped, that means it is the good one. So during the exercise, what will happen? There will be tachycardia and there will be vasodilation that will lead to decrease in the AR, right? So significant symptoms only in severe AR. Asymptomatic, palpitation, fatigue, dyspnea, increase in the JP, pedal edema, breathlessness, these will be the complaints. So angina, okay. Now nocturnal angina, why nocturnal angina? During the sleep there is decrease in the heart rate, and there is decrease in the heart rate that will increase the AR, right? So we will see the known signs of AR now. There is a Corrigan sign. That means there would be a prominent carotid and supraclavicular pulsations. That is the Corrigan sign. We have Muller sign. That means a uvula to see the uvular pulsations. Alfred de Musset sign, that means there will be head nodding with the heartbeat. So in my patient, Alfred sign was not present, uvula sign was present, Corrigan sign was present. Because sign, that means there is a retinal artery pulsation. I have remembered with RR. Okay. Rosenbeck sign, that means there is a liver pulsations. Gerhardt sign, that is the spleen pulsations. Lighthouse sign, that means there is a blanching and flushing of the forehead. Then we have the Durézius sign, that means intermittent to and fro femoral artery systolic and diastolic murmur, okay, generated by the light compressed with the bell. Then there is a Hill sign. Hill sign, that means we need to compare the lower limb and upper limb's blood pressure. So lower limb systolic blood pressure and upper limb systolic blood pressure, there will be a difference of more than that of 20 mmHg. That is a Hill sign. So remember, lower limb and upper limb, then it is a difference 15 mmHg Hill sign. Water hammer pulse, we all are very familiar with that of collapsing pulse, water hammer pulse, right? So high volume, abruptly collapsing pulse. Then there will be a Lincoln sign, that means there is a pulsatile popliteal. Mayan sign, that means whenever the diastolic blood pressure drops when the arm is being raised, that is dropping by 15 mmHg, right? That is a Mayan sign. Sherman sign, that is the dorsal pedis pulse is unexpectedly prominent in the age more than that of 75 years. Dorsal pedis and Lincoln's sign is a popliteal. So these signs have to be remembered because they are asked in the vivas also, final exams also, right? Coming to the collapsing pulse, how will you describe it? So that would be an upstroke, then it will be an insistent peak, then it will be a downstroke, and it is a high volume. So collapsing pulse can be present in normal individual with that of hyperdynamic states. That means it can be in anemia, in pregnancy, in fever, in beriberi, okay? Thyrotoxicosis. Then diastolic runoff. Diastolic runoff, that means the blood is coming back, right? It isn't seen in AR, it is seen in AV fistula, it is seen in PDA also. Severe MR, it is a pseudo collapsing pulse in severe MR. Then coming to pulses bispherians, that means there are two peaks that are present in systole, right? Okay, both occurs in the systole. So how will you determine? So this is the percussion wave, this is the tidal wave, this is the dicrotic notch, and this is the dicrotic wave. Okay. So, seen in HOCM, okay, severe AR, AR with that of the AS. So, there will be a wide pulse pressure, there will be a diastolic thrill, okay, wide pulse pressure we have already seen. HOCM, we will be talking about this later on, and AR with AS. Mostly in 2D echo, we get these findings with because of the age factor, calcification, or degeneration that is taking place. And then we have a diastolic thrill, right? So S3 and S4, in case of failure, we have already seen it could be present, but there is in S2 there would be a narrow split, okay, and A2 would be variable intensity. Now the murmur, there are three types of murmurs. So it could be a diastolic murmur, it could be a systolic murmur, and it could be a mid-diastolic murmur also. So I am thrilled and that I could recognize the diastolic as well as systolic murmur. Okay. So we will see of the early diastolic murmur and the mid-diastolic murmur what it is. Now there is a difference between both, and it is very difficult for us to actually know how is this early diastolic and mid-diastolic murmur and what to see in this. So this early diastolic murmur is actually a high-pitched one, but the mid-diastolic murmur is a low-pitched one. The mid-diastolic murmur will be disappearing after that of the S3. Okay, and this early diastolic murmur is something which would be present, and it is a high pitched one, and it would be something which is starting from the A2 okay, and it is best heard in second intercostal, right? Which would be sitting and bending forward in expiration. Then it is a decrescento murmur. We are aware of it. So this murmur, whenever it is heard best on the right side, so it is the valvular root pathology, and if it is the left side, then it is a valvular pathology. Okay, so this could be determined. And then we have the mid diastolic murmur, that is an Austin Flint murmur. So this murmur is something which is in eccentric AR, severe eccentric AR it is heard in, and it is heard in the apex, right? It is a low pitch, okay, and it disappears after S3. Then there is something which is cholecyst's murmur. So this is not very pathognomic, but yes, this could be asked as an MCQ. And of course, I was when I heard this murmur in my patient, I was a little bit confused with that of MR or it is AR before doing the 2D echo. So, as this sign says that there is an axillary diastolic murmur in the aortic insufficiency. So, I could hear some murmur in aortic and in the axillary part, and I thought it should be a pansystolic murmur, but then again, because it has also a diastolic murmur, so I was confused, a bit confused. But yes, I could just say it is a systolic and it was a diastolic plus, right? Um, then there is a key Hodgkin's murmur. That means there is an diastolic murmur of AR with a raspy quality. Now, this is because of the key Hodgkin's murmur because of the retroversion of the aortic valve leaflet. There is a cooing toe murmur. That means there is a musical quality version and because of the eversion and perforation of the aortic cusp. For the marker of severity, we have already seen the length of the murmur depends, and the peripheral sign says it all. And of course, there would be presence of the cardiomegaly. There will be increase in the JVP and pedal edema. Okay. So the Boston flint murmur, the mid-diastolic murmur, the early systolic murmur. This will give us the finding that it is a severe kind of the AR. Okay. So any of the symptoms which is a severe AR, then there should be a white pulse pressure, collapsing and disference pulse. Peripheral signs would be present, cardiomegaly, forceful apex, then there is narrow split of S2, early diastolic murmur, Austin flint murmur, and left ventricular dysfunction and pulmonary hypertension. For the investigation, we all know that would be LVH, and there will be cardiomegaly, and then 2D echo, of course, will be saying it all. There are certain of the indexes that could be helpful for us to determine if whether it is a mild, it is a moderate, or it is a severe one. So if it is a regurgitant width upon the LVOT width, this is mild, moderate, severe. So it is less than 25%, 25 to 65%, more than 65%. And coming to the pressure half time, mild, moderate, severe, more than 500, 200 to 500, and then there it should be less than that of the 200, right? And diastolic flow reversal in a descending aorta, of course. Okay. So we have a vena contracta which is more than equal to 0.6 centimeter, regurgitant volume more than 60 ml, and then effective regurgitant orifice which is more than should be 0.3. This is a MCQ thing, right? Remember this. Okay. So we have the marker of the chronic severe AR. So the width more than 65%. Then the we have already seen the pressure half time should be less than that 200, and if it is more than 500, it is a mild only. Then vena contracta more than 0.6. Then in a regurgitant volume more than 60 ml, right? For the treatment part, the medical therapy is not very useful. It is the surgery which should be done and stabilize the patient with the AC inhibitors or hydrolyzin, or we have nifedipine, and treat the comorbidity. Surgery is very important. Whenever there is a left ventricular end-diastolic pressure is more than the ejection fraction is more than that of say 55%, the surgery has to be done even the patient is asymptomatic. And symptomatic patient, it is definitive surgery management is to be done. In acute regurgitation, it could be because of infective, that is an acute condition, or trauma or aortic dissection. So surgery emergency, and patient will be coming with tachycardia, hypertension, cold extremity shock. There is no peripheral signs, soft S1, diastolic murmur is not present, right? So treatment comes with the aortic valve replacement. So I hope you have enjoyed this video. Thank you so much for the watching. I'll see you next time. Bye.